Hello everyone, and welcome to Heads Up, the official weekly podcast of the National Headache Foundation. I'm Dr. Lindsay Weitzel, migraine strategist and lifelong migraine survivor. I am here each week with Dr. Vincent Martin, MD, director of the Head and Facial Pain Clinic at University of Cincinnati and president of the National Headache Foundation. Hello, Dr. Martin.
It's a pleasure to be here.
So our topic today is what can we do to advocate for ourselves? We happen to be here at Headache on the Hill in Washington, D.C., which is an awesome place where our patient advocates from all over the nation gather in order to ask for things of Congress to help migraine patients. So our topic obviously has to do with advocating for ourselves. So here we are advocating on the national level. So can you talk about what we're doing here at Headache on the Hill?
Sure, I'd be happy to. So when you advocate on a national level, what you're looking to do is change national policy. So one way to do that would be to change funding for headache disorders through national organizations like something called the NIH, the National Institutes of Health. So one of our goals over the last 10 years has been to increase funding on headache disorders. You might ask, well, how does that really improve things for a headache patient? Well, all the disorders that have had more specific funding through the NIH have been able to develop new and exciting therapies that help patients with their disorders. So our hopes would be to develop a greater understanding of what causes migraine and other headache disorders and to develop new treatments. So that's one thing. And another thing would be that sometimes there are certain practices through certain governmental organizations that are not particularly favorable to various headache disorders. One example of that would be oxygen for cluster headache patients. So one of the best therapies to get rid of cluster headache would be to use inhaled oxygen. So you have to have this big oxygen tank. Mm-hmm. And currently both Medicare and Medicaid do not approve this as a therapy to get rid of a cluster headache. And for those of you who don't know what a cluster headache might be, it's a very severe headache that's usually on one side of the head. That's usually a 10/10 in terms of pain severity. And then it usually has tearing the eye and running the nose to go along with it. It's really one of the most severe forms of pain that you can get. So not being able to treat that with oxygen is a real detriment to these people receiving adequate care. And then the third thing is that when there are some patients, it's not a huge number of patients who are actually disabled with migraine. So they can't work, they're not very functional. Maybe they're having 3, 4, 5 days a week with severe and incapacitating headaches. Oftentimes they're not particularly responsive to either preventative therapies to try to reduce the frequency, or what we call abortive therapies or acute therapies to treat the pain when it comes on. So they're left with these severe and incapacitating headaches and they can't work. Or they've tried 2 or 3 different jobs and maybe they're missing 5, 6, 7, 10 days a month. You can imagine that the employers aren't going to wouldn't really stick with them in that kind of situation. Well, right now, when you apply for Social Security disability, what happens is that there's something called the Blue Book, where the Blue Book actually lists all the conditions that qualify for disability, and then also the very specific requirements under each disease that will tell them if someone is disabled. But the problem is that there's no specific category for migraine or other headache disorders. So the problem with that is that they oftentimes have to use another disorder, basically a seizure disorder. And the reason why they chose seizures was because both migraine and seizure disorders are episodic disorders that can cause disability, but they're just not similar in any way, shape, or form. So they're trying to apply criteria for a disease that really doesn't even relate with headache disorders. Consequently, migraine patients are much less likely to get disability from the Social Security Administration as compared to other disorders. So we're trying to change that. We're trying to see if we can get that added as a new category in the Blue Book for the Social Security Administration for disability determination.
Right. It's so important to add us to the book because we have the second most disabling condition globally, and we aren't even in the book in order to help us get disability. So that's a great, important thing to do here at Headache on the Hill. Maybe we can go a little bit to how we can advocate for ourselves as opposed to just nationwide. What can we do personally for ourselves? Because, some of us, not everyone can get here to Washington, and people have issues when they have chronic headaches. So what can we do?
We'll first talk about what are some of the issues, and then we'll talk about what potentially you can do. But one of the big issues is that there are some new medications that have come out that prevent headaches. And there are some insurers that will require that a physician be certified in headache medicine by something called UCNS. And that's basically a certifying organization nationally. But the problem is there are only about 600 or so doctors that have this UCNS certification nationwide, and there are some states that have absolutely zero. So there was one insurer, for example, that came out with the policy that to receive this new preventative medication, that you would have to be ordered by a physician that was UCNS certified, and there were no doctors in the entire state that actually had that certification. So in effect, what they did was they shut an entire state out of receiving this new class of medications, which obviously is not the best practice. Other situations have come up with the same group of medications where there have been states where there's only 8 or 10 of the UCNS certified docs for the entire state, with a condition where that includes 7% of the entire U.S. population. 7% of their entire state has migraines. So you can imagine that group of people would be absolutely overwhelmed by trying to prescribe that medication. So there's situations like that. There's other situations where there can be quantity limits on the number of what we call acute medications. So for migraine, so an acute medication is one that's used to try to get rid of a migraine attack. So you take it and try to get rid of it. Well, there's some medications that are modestly expensive, so consequently the insurers will try to limit their quantities. And in some cases, they limit it down to 3 or 4 tablets per month. And you can imagine that if you're having 12 to 15 migraine days a month, that 3 or 4 tablets will last you probably about 2 or 3 days.
Right.
And there are things that you can do. The first thing you have to realize is that your doctor could do something called a prior authorization, which is where some form gets filled out and you submit that to your insurance company, and then in some cases they might increase the quantity up to a certain level. Although you have to also realize that that's a lot of work for your primary care physician or your specialist. Oftentimes it may take a half an hour of your staff's time just for one prior authorization. So it gets to be kind of egregious. So those are just 2 instances where people can run up against barriers, mostly on the part of the insurer. But so if that happens, what you can do is there's something called a health commissioner for each state, and you can write a letter to your health commissioner describing what the situation is, describing what, in your opinion, is the inappropriate practice by that company, and then the health commissioner will then contact your insurer to try to mediate this thing and see if they can rectify the solution.
Right. I can say that as someone who had daily migraine for 26 years, the access to care problem is huge for us. It's a huge problem. And access to treatments. While I was once waiting for the process of getting some medication the amount was cut a little low by my insurance company, I got a migraine that caused me to black out, and I fell flat on my face, and I ended up in the ER. Then I had a whole ER visit because they had to stitch up my face and they had to bring in a plastic surgeon. So these things, you can really get hurt, you can really get sick while waiting for people to step up and help you with your meds and your access to care. So it's really important to advocate for yourself and take those steps. So my next question is, I think there's something called step care that a lot of us deal with. When we go in, there'll be certain medications that are FDA approved that are for us, yet we might have to try some medications that aren't as effective or aren't FDA approved for a headache. So can we talk about that?
Well, step care is just simply where you have to fail. Usually it's several medication classes. Usually it involves preventive therapies that usually are take a daily pill, for example, that's taken on a daily basis to try to prevent, say, migraine. And oftentimes you'll need to fail less expensive medications, often that have higher side effect profiles, before you can use the higher priced medications, which in some instances have less side effects. And what's really interesting is there are even times where the medication classes that you need to fail are not even FDA approved.
Right.
So they're asking you to basically fail drugs that have not even been formally approved by the FDA for the treatment of migraine headache, which I think may not necessarily be appropriate. But so those are things too that theoretically one could write to the health commissioner if it was really egregious. But by the same token, I think patients also need to realize that there needs to be a balance. You can't kill an ant with an anvil, So many times it may be reasonable to try some of the less expensive meds first before you go on to a more expensive med. But there needs to be realistic trials, and there shouldn't be so many hoops that you have to jump through as a physician or as a patient to get a medication approved.
Right. All right, well, is there anything else you wanted to add to our topic on advocating for ourselves today?
The only thing I would say is that patients need to become active in advocating for their own problem. Simply, so if you have the ability to come to Headache on the Hill is great. I think you'd meet a lot of persons with migraine and other headache disorders that are very fervent in their beliefs that to try to help improve the situation for headache disorders or headache sufferers throughout the world. Or if you don't have that capability, you can write letters, to various people. In probably the weeks and months to come, there will be ways for you to identify who your health commissioner might be in your state with an address and possibly with a name. And then you can actually then write letters if you have some of these issues with the insurers or other situations that you think are not reasonable.
Right.
So the main message is you need to advocate, for yourself. Just don't sit back and let things happen, because if you let things happen without really taking any action on it, you're just going to be steamrolled.
Right.
Nothing's going to ever change with your headache disorder.
Right. So even though we all feel sick, the best way to take care of ourselves is to advocate for our condition. I really believe that that's true. So this is Lindsay Weitzel signing off with Heads Up, the official weekly podcast of the National Headache Foundation. We will see you next week.